Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of welcoming to the podcast my dear friend and colleague, Dr. Alejandro Rauh-Hain, who is in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center. And the reason for the podcast is the recent article that was published in JAMA Network, laparoscopic saddle reduction after neoadjuvant chemotherapy in high-grade epithelial ovarian cancer, a LANS randomized clinical trial, long-awaited study, and certainly, obviously, we're looking forward to the discussion. Alejandro, welcome to the podcast, and it's great to have you again, and I hope you're doing well. And once again, thank you for accepting our invitation.
Thank you so much, Pedro, and thank you and the journal for the opportunity to be here. I'm very excited to talk about the LANS trial.
Excellent. So obviously, an important study, a study that you have led, and you have put a great deal of effort into not only the study design and the implementation of the study, but also obviously all of the the effort that it takes to open it at multiple sites. So I wanted to start by discussing where are we with regards to the use of minimally invasive surgery in advanced ovarian cancer.
So really, the LANS trial highlights the growing use of minimal invasive surgery for ovarian cancer. So there are plenty of observational studies that have suggested that, and this is very important, for selected patients who respond very well to neoadjuvant chemotherapy, MIS can achieve comparable outcomes, and particularly what we know from the observational data is short-term outcomes compared to laparotomy. And there are a couple of other observational larger studies that, and some of them have been published by our group, that have demonstrated that those patients, again, selected patients that undergo MIS have similar also long-term outcomes compared to laparotomy. But the issue is that all of this is observational, and most of those studies, or I would say all of those studies, have a huge selection bias in the sense that very likely the patients that are undergoing minimal invasive surgery are those patients that have better response to neoadjuvant chemotherapy. But I would say that, at least in the United States, if you look at the recent data, it is actually a commonly used approach, and we can talk more about that.
Great. So then, obviously, this leads us to the LANS trial, and I know, again, obviously, when we had the initial discussions of the LANS trial and the trial design, can you share with our audience what was the impetus to put this together? Some might say, why a randomized controlled trial to address this question?
Yeah. So the impetus really came from the growing use of MIS in advanced ovarian cancer without really strong evidence to support that MIS is equivalent to laparotomy. So if you look at the data that's available, I mean, we all know that the rates of neoadjuvant chemotherapy are increasing dramatically, or have increased dramatically in the last 10, 15 years in the United States. I think maybe around 50 to 55% of the patients with advanced stage disease in the US receive neoadjuvant chemotherapy. So those numbers are, again, have increased year over year. But I think, to me, what it's even more important is when you look at the most recent years, close to a third of the patients in the United States, a third of the patients that receive neoadjuvant chemotherapy are undergoing their interval debulking surgery through a minimal invasive approach. And that raises the concern that, again, a third of the patients are undergoing this approach just only based on the observational data. So given the higher rates, that's why we really decided to launch the trial, to really confirm that we're not hurting the patients by performing this interval debulking surgeries through laparoscopy or robotic surgery.
Yeah. And of course, obviously, when looking at those numbers, it's very interesting that, as you mentioned, a third of patients are undergoing minimally invasive surgery based on just data from observational studies. And this is particularly very important as the rates of neoadjuvant chemotherapy
Yep.
continue to increase. So
Yep.
the absolute numbers may be, certainly quite substantial in this arena. So with that, then in this publication, you are providing the results on a feasibility study. Tell us about the design of this initial phase of the study, and if you could really focus on also what were the inclusion criteria?
Yeah, so the study was designed with as a two-phase, like two separate steps. Overall it's a phase 3 randomized trial, right? But there were two steps. The first step, the feasibility step, was really to assess whether we can accomplish the study. So in the feasibility phase, it was 100 patients. We wanted to evaluate whether it was practical to conduct the trial, and we had a couple of endpoints that we were assessed that we decided to assess in terms of feasibility. And so we wanted to make sure that we could enroll enough number of patients in a certain period of time. We wanted to assess that the conversion rate was not very high in those patients that had minimal invasive surgery. And we wanted to make sure that the optimal seroreduction rate between open and minimal invasive surgery were equivalent. So again, the first 100 patients, we're really trying to assess whether the trial was feasible or not. And that is the whole manuscript that we just recently published. In terms of the inclusion criteria, we included patients with advanced stage ovarian cancer, high-grade ovarian cancer, that had received three or four cycles of neoadjuvant chemotherapy. And I would say the most important criteria is that they had to have a normalization of the CA125. And then, in addition to that, on imaging, the surgeon who was going to perform the surgery needed to feel that they could perform the operation either through a minimal invasive approach or an open approach. There was a lot of controversy about the normalization of CA125, and a lot of concern about other, some groups stating that it's very rare to see normalization of CA125 after 3 or 4 cycles of neoadjuvant chemotherapy. The reality is that when we look at our institutional data, in addition to data from Mass General in Boston, we've seen that around 25% of the times, and between 25% and 30% of the times, actually patients normalize their CA125 after receiving 3 or 4 cycles of neoadjuvant chemotherapy. So it actually happens more often than I think people realize. And the other part that it's, I think, very relevant, it's to keep in mind that we really wanted to select the patients that were going to benefit the most for minimal invasive surgery. So we were trying to figure out what kind of markers or predictive markers we can find to really select those patients very well for the trial. And there is some data from Anna Fagoti suggesting that normalization of CA125 could help us predict who were those patients that would benefit from a minimal invasive approach.
So now, Alejandro, with that, can you tell us a little bit about the actual intervention in this particular study? What were the outcomes of the study?
So the intervention is the patients are randomized to either minimal invasive surgery, and that includes laparoscopy or robotic surgery, or they were randomized to the control group that is laparotomy. I would say that the most important thing, and we let really the surgeons decide about, the operation. I mean, they have to, as long as they achieve an optimal site reduction to no residual disease, how they place the ports, how many ports, and so forth. It's really, particularly for the minimal invasive for the patients that are randomized for minimal invasive surgery, we allow the surgeons to decide all of those things. I would say the most important thing in that sense is that all surgeons that are participating in the trial know that if a patient is randomized to minimal invasive surgery and they don't think that they can achieve an optimal cell reduction to no residual disease through MIS, but they could do it if they open, then they have to open the patients. And actually, again, part of the feasibility study was we were expecting to have some patients that are converted to open surgery. So we don't want to compromise the oncological outcomes. So again, I think this is a very important point that if a surgeon feels that they cannot achieve the surgery through MIS to achieve a no-residual disease, they know that they have to convert to laparotomy. The other important thing is that we allowed for patients that are randomized to minimal invasive surgery to have a mini laparotomy, and so like as long as the incision is less than 8 centimeters, that is considered per our trial as a mini laparotomy, and that is not considered a conversion. If it's more than 8 centimeters, then at that point we consider that as a conversion to laparotomy. Why 8 centimeters? We tried to look at definitions for mini laparotomy, and that's what the one that we found. But it's, again, it's a little bit arbitrary, to be honest.
Very well. Now, let's go to the results. What did you find in the study, and what are some of the main highlights you want our audience to take away?
Yeah, so just to go back, so the main outcome was to assess for feasibility. So there were 3 feasibility endpoints. One is we wanted to make sure that the conversion rate from laparoscopy to laparotomy was less than 25%. We wanted to make sure that there was not a significant difference, less than 20%, in the rates of complete resection between minimal invasive surgery and laparotomy, and that we were able to accrue enough number of patients to complete the larger, the larger phase study. So in terms of the conversion rate was 13%. And looking at the 95% confidence interval was way below the 25% benchmark that we had. When we look at the complete gross resection between MIS and open surgery was 88% for minimal invasive surgery and 83% for laparotomies. So it seemed to be higher with minimal invasive surgery. And you can argue that perhaps it's because with laparoscopy you don't feel, and there might be some biases there, but at least what we can say is that it doesn't seem that minimal invasive surgery is hurting patients by having lower rates of complete gross resection. And then finally, by the last month of the study, we were almost enrolling close to between 5 and 6 patients per month, suggesting that we were able to complete the larger study within a reasonable time frame. So those were the big findings just to assessing for feasibility. We also look at hospital stay. It was shorter for patients that had MIS, as you may imagine. Also, there were lower rates of complications in the MIS group compared to laparotomy. And also, looking at quality of life, it suggested that patients that receive MIS had better quality of life. Although, again, with only 100 patients and only almost half of them having MIS, it was not a strong signal, but it was definitely, it suggested that patients with MIS had a better quality of life. Sorry about that.
Mm-hmm. Yeah, so definitely there was meeting the feasibility primary endpoints, and actually all 3 feasibility primary endpoints. Yeah. So with that, then let's get into some of the questions that were submitted by the fellows in the journal. The first question is, what are the criteria for neoadjuvant chemotherapy administration in this study? Were these only patients where complete resection was just not possible in primary surgery, or also patients with high tumor burden?
Yeah, it's a very good question. And we don't have any specific criteria of like, we're allowing any patient that receives neoadjuvant chemotherapy for any reason to be enrolled in the study. I would say the vast majority are patients with high disease burden. But yeah, we are allowing any patient that receives neoadjuvant chemotherapy.
So the next question, with regards to surgeon proficiency.
Yep.
This question comes from one of our fellows says, many often will question the technique of the surgeon in surgical trials. Can you give us just an overview of what the surgeon evaluation process was in the LANS trial?
Yeah, so every surgeon that performs minimally invasive surgery in the LANS trial has to submit two unedited videos um, while they are performing an intraoral debulking laparoscopic or robotic um, surgery. And those videos are assessed by our group, and we have a formal way in which we um, grade those videos and the things that we look for. Um, I think, as you better know, um, surgeon proficiency is something that, like, I think the hardest thing for a surgical trial is, how you assess the intervention, right? And surgeon proficiency is something that it's always going to come up as a limitation in any surgical trial, even though that we try to standardize as much as possible. Um, so the best way that we thought that we can assess for that or control for that at some degree was to watch the surgeons doing those videos and have a formal assessment of them doing the operation. So that's what we've been doing.
Excellent. As a follow-up to that, then also a question comes up with regards to the criteria and the selection. So the question is, what imaging tests were used in the study to assess response to neoadjuvant chemotherapy and the subsequent feasibility of the MIS approach?
So we only, this is per institutional or surgeon standards. So at least they have to have a high quality CT scan of the chest, abdomen, and pelvis to assess for the response. There are some institutions in which they also might do an MRI and a PET CT, but it really, as long as there's a CT scan that shows a response, and again, it's a very pragmatic trial in the sense that we allow the surgeons to make the decision whether they think whether the patient is an appropriate candidate for the trial based on imaging.
Now, you mentioned previously the CA-125, and interestingly,
Yep.
you mentioned that it's almost a third of the patients where the CA-125 normalizes at the 3 or 4 cycles.
Yep.
So this next question goes to the point of, in the next phase of this trial, the phase 3 of the LANS trial, I believe you mentioned that CA-125 levels do not need to normalize. So how will CA-125 values after neoadjuvant chemotherapy be considered in the next phase of the study?
So as we talked before, for the first 100 patients for the feasibility phase, patients have to normalize their CA-125. And again, we were trying to look at ways to predict who are the patients that benefit the most from minimal invasive surgery. So when we look back at our numbers, and this is data from MD Anderson, we looked at what happens to patients with CA-125s between 35 and 500. Are there any patients in that kind of group in which they have actually such a good response that you can attempt to do minimal invasive surgery? So we did a retrospective review of those cases, and we found that there was a substantial number of patients in which they had a kind of straightforward surgery. So we were missing those patients in the LANS trial. So we decided to amend the protocol, and now we allow patients to be enrolled if they have a CA-125 between 35 and 500. The important thing is that for that group, again, because we want to be very selective about who we offer the trial and who are actually candidates for minimal invasive surgery. So if a patient is between those CA-125 cutoffs, they have to have a diagnostic laparoscopy. And if during diagnostic laparoscopy, and this can happen as a one step, the surgeon feels that they can accomplish the surgery, meaning a complete cell reduction, either minimal invasive or open, then the patient is randomized intraoperatively in the LANCE trial. So again, so now there are two ways in which we can enroll patients. One is if you have a normalization of CA125, we can randomize them before surgery. That's like the usual approach for the feasibility phase. But now we have this other approach that if their CA125 is 80, the imaging looks very good. The patient can go to the OR, has a diagnostic laparoscopy. The surgeon assess. There's not a formal assessment, so there's not like a specific score that we are looking at. It's really the surgeon's ability to say, okay, we can complete this surgery MIS, or sorry, minimal invasive. And then at that point, if a surgeon, again, based on their assessment, intraoperatively says, okay, we can proceed with surgery, then we can randomize the patient intraoperatively, and then they can have their surgery at that moment. So we have designed all this process to do the randomization intra-op while the patient's already asleep, undergoing the diagnostic laparoscopy.
So Alejandro, one of our fellows is interested in the operative time. And he was asked with regards to the median and the range of the operative time between the two groups, minimally invasive versus open.
I don't think we have the operative time for all the cases, but for the ones that we've done, but we definitely MIS is a little bit longer, but I don't think it's significantly longer. But I don't think we're formally recording for all the cases that I'm aware of.
Okay. How about surgical complexity?
Yeah.
One question comes in with regards to the median surgical complexities was a score of 2 for both groups. Can you provide some more details with regards to the procedures that were performed?
Yeah. So based on the criteria that we're using, right, like normalization of CA125, the imaging, these are patients that have profound response to neoadjuvant chemotherapy. So the expectation is that most of these patients would all require a hysterectomy, bilateral salpingo-oophorectomy, and an omentectomy. We have had patients in the LANCE trial that have had diaphragmatic resections, patients that have either MIS or open, splenectomies, rectosigmoid resections, and so forth. So there have been patients in which either MIS or open, they have had more radical surgeries. But I would say for the vast majority of the patients, they have just a standard hysterectomy, bilateral salpingo-oophorectomy, and omentectomy. I honestly think that this approach should be reserved for those patients that have very good response to chemotherapy.
Yes, completely agree. Certainly a select patient population. This next question is regarding those patients that went to laparotomy in this study. Yeah. Was a preliminary laparoscopy done to assess resectability? How frequent was this the case?
No. So if a patient is randomized to open surgery, they don't undergo a laparoscopic assessment. It's a very good question. And when we started designing the study, one of the ideas that we kind of like thought in the design of the study was, should every patient have a laparoscopy, and then laparoscopy should be kind of like the entry point into the study. We thought that if we did that, it was going to be like, for many institutions would have been very challenging to implement, and that's why we didn't do it. So no, like patients that are randomized to open surgery, they don't have a laparoscopic assessment. I would say that there have been a few cases in which we have had suboptimal site reductions, but that hasn't happened very often.
So now one of our fellows interested in robotic surgery, he's asking, in this study, robotic surgery was only used in one patient. Why? Do you believe that robotic surgery may offer advantages over laparoscopy in this type of surgery?
So I'm very biased because I do mostly straight stick laparoscopy. So to me, either straight stick laparoscopy or robotic surgery is just a tool. And I think people that are very good laparoscopists can perform the same operation as someone doing robotic surgery. So, to me, I don't think there should be a difference. I'm sure there's other surgeons that might disagree with this assessment, but again, based on my experience, I think it's the same. Um, and we're allowing robotic surgery. I mean, there are centers in the U.S. that are enrolling patients in lands that have access to robotic surgery. It's just that you know hasn't happened that often.
Now, question that obviously will come up
Yep.
as there is further discussions on the studies, the use of HIPEC.
Yep.
So with HIPEC permitted during
Yep.
surgeries in both arms of the study,
Yep.
how might this influence the outcomes? And should you take some more strategies with regards to stratification in the next phase of the trial?
Yeah. So when we designed the study, we kind of like we ask experts in the field to assess what kind of population would they want to include in a trial like this. And we went all the way from like a very narrow patient population, only 3 cycles of neoadjuvant chemotherapy, no other trials, no other interventions allowed, all the way to a more liberal inclusion criteria, like up to 6 cycles of neoadjuvant chemotherapy, they could receive all the interventions and so forth. And pretty much like the feedback that we received was like something in the middle. And the question of HIPEC came about, and I think it was very clear for many of the institutions that said that they would not participate or enroll patients if we didn't have the option to offer HIPEC in the trial. So we decided to allow HIPEC in the trial. Every time that a patient is like a surgeon is thinking about giving HIPEC, they have to let us know in advance. We actually have to review their HIPEC protocol to make sure that it's within the standards. So first of all, we have to approve that. And then HIPEC is actually a stratification factor in the trial and has been for the feasibility phase and now for the large phase. To the point that, I mean, HIPEC, I think close to 20% of the patients in the trial receive HIPEC or are receiving HIPEC, and I think those numbers are going to keep going up. Actually, we submitted a couple, like an abstract at ESGO and SGO, looking at the experience of the Lance trial with HIPEC. So I think we're going to have interesting data at the end of the trial. But yeah, I mean, I think the short answer to the question is we're stratifying by HIPEC, and that's the intent of HIPEC before surgery.
So this next question, Alejandro, it's on quality of life. In the
Yep.
LAC trial, as you know, we found really no difference between MIS and laparotomy, which was
Yeah.
also another unexpected finding of the LAC trial. What did you find in this, of course, obviously this feasibility trial as it pertains to quality of life?
So we found better social functioning in the minimal invasive surgery group at their first post-op visit, with no significant difference in other domains. Keep in mind that it's a very small number of patients, so it's very hard to come up with any meaningful conclusions. So we'll see what the larger phase study shows. I think it's interesting looking at quality of life in a surgical trial, and perhaps the measurements and the time frames and the time points that we are using to assess for quality of life in surgical trials are not the correct, first of all, endpoints, and second of all, the right time frame. So, we spent so much time discussing about this when we designed the study, but we'll see what the results show. But I have had second thoughts about whether there's there's definitely a need for obviously surgical trials, but I think that being more thoughtful about these endpoints and whether you can use the same tools that we use for other types of trials into surgical trials, and also what are the right time frames in which you should be doing the surveys. I mean, do you really expect to find a difference 6 months after an intervention? I think it's unlikely, right? I mean, most likely you're going to find a difference in the first 3 months, and I think those difference you would assume that would dissipate over time. So I think it's a very important question. I think there's a huge need in the field to start evolving that. So if there's any junior faculty who's looking for a niche in their career, I would say this is a perfect niche, because honestly, I don't think there's much people doing like quality of life, particularly for surgical trials.
Yeah, and particularly so given the fact that many of these patients will go on to have additional adjuvant therapy, either in the form of chemotherapy and subsequent PARP inhibitors. So
Exactly.
long-term quality of life, obviously, you have to take that into consideration. So I just have a few more questions. I know you're trying to catch a flight. So one of the questions from the fellows was also, do we have any preliminary results on survival data from this lead-in pilot phase of the lens?
So survival data is the primary. I mean, PFS is the primary endpoint, but we are not allowed to look into it overall survival either at this point. So we don't have any data right now to share.
Okay. What do you consider are the weaknesses of this study that has been published already?
So I would say that everyone that has run a surgical trial knows how hard it is, and you better know firsthand and then secondhand by all the mentorship that you provided in this trial. And I would say the hardest thing for surgical trials are, first of all, to get the funding to do them, and then finding collaborators that want to participate into the study. I mean, all of those is just extremely hard. And then the other part is, you really, and goes along to the question you were asking about the weakness, is how can you really assess the intervention, right? For a drug therapy trial, it's easy, right? You just give the chemotherapy. As long as there's scheduling, you're fine, and you can assess objectively that. How can you objectively assess whether the surgeon is performing the operation that you intended to do every time, not only in the videos that they send you? That's a much harder question, right? So, and that's just part of doing the surgical trials. But even though that, and I think to me that is the biggest weakness. But having said that, I don't think just because we cannot like assess that every time, it doesn't mean that we should not be doing surgical trials. I think surgical trials are extremely important. We've seen that in the past with the LAC trial, but in other trials that have really changed the standard of care. So, um, so I do think that we have to, in order to move the field forward, we have to keep innovating, thinking about better ways of doing surgical trials, open more surgical trials, and do not assume that low quality observational data should be driving how we treat patients. I mean, you can use high quality observational data, and there are different methodologies that you can use to have better sense, right? Um, but again, I think we have to be very careful when you are using low quality observational data to dictate how we treat patients.
Alejandro, when do we expect the second phase of the study and the data to be all fully complete and mature?
I'm hoping that we can finish the trial before you retire.
Remember, I already did that once.
Exactly. Um, Joking aside, we have projections to finish in enrollment in 3 or 4 years.
Okay. And then one last question, Alejandro, because I think it's important to highlight this. Should the results of this study that was recently published, the
Yep.
feasibility, should this now be taken as, well, these are the results, they seem favorable. Now my new standard is going to be MIS moving forward.
No, I mean this study just shows really that in the short term, patients that received minimal invasive surgery had better short term outcomes, and that the larger phase study was feasible. So I don't think so. I mean, to the point in our practice, we only offer minimal invasive surgery on the trial, and we don't offer it off the trial because, again, if you look at the data and some of those papers have been published by our group, I don't think we have enough evidence to suggest that it's safe. I would say that, in my opinion, it's different than cervix cancer in the sense that patients, obviously completely different disease, but also patients are getting chemotherapy afterwards. So if you're not having the same kind of quality surgery, whether the extra chemotherapy can overcome that, perhaps. But I think we don't have enough evidence. I mean, I think, to me, it's pretty scary to think that a third of the patients in the US are getting MIS without any strong data.
Excellent. So, Alejandro, thank you so much once again, of course, obviously, for taking the time just prior to boarding a flight, and we really appreciate your time. Congratulations, of course, on the implementation of this first phase of the study. Best of luck in the continuation of the study, and we're really looking forward, of course, obviously, to the final outcomes of the LANS trial. So, thank you once again, and hope you have a safe flight.
Thank you. And I would say, if anyone is interested, who's hearing the podcast, in participating in the trial, please feel free to send me an email. We're still looking for sites. We don't have that many openings for more sites, but I think we have maybe opening for four more sites. So please send me an email. My email is jarauh@mdanderson.org. And Pedro, thank you so much for the podcast. This was very fun.
Excellent. Always fun to speak with you. And thank you once again.